Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and chief medical officer of NEI, Dr. Andrew Cutler, sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast, and today I'm really excited to be speaking to somebody I've admired for quite some time, Dr. Neill Epperson, who is at the University of Colorado and truly is one of the world's authorities on women's mental health.
Great to be here, Andy. Thanks so much for giving me the opportunity to talk about something I'm so passionate about.
Absolutely, and it's really timely. It just seems like there's been a lot more attention paid to this, rightfully so. So let's talk a little bit here, get started about, we hear women presenting with cognitive complaints in a variety of situations, obviously in the menstrual cycle, menopause, various phases, and certainly with many of our psychiatric conditions, cognitive impairment is a big part of it. People use terms like brain fog, and I think I might have dementia and things like this. Why do you think this is becoming so apparent now? What's driving this?
Well, one, I think menopause is a hot topic right now, specifically. And women, for example, that may have had mild ADHD or attention deficit hyperactivity disorder growing up, but they're super successful. And so they think, oh, I've kind of overcome this. They may not have even recognized that they had these symptoms. And you take the hit of having sort of maybe a subclinical level of executive functioning challenges, and you put somebody into a menopause situation or a very stressful situation, such as, I'm now CEO of this company and I've never been a CEO before. So all of a sudden, you've done multiple things. You've maybe taken a biological predisposition. Again, it doesn't have to be there. They may have never had ADHD symptoms, and I've seen many women with completely new onset of symptoms of executive dysfunction as they go through menopause. And again, it's pretty darn common. But women are talking about it now, and I think they're talking about it more because just menopause in general and hormone therapy in general, we went through that long period after the Women's Health Initiative where nobody wanted to deal with this. Now everybody's dealing with it, and people are more vocal. So I think that's terrific.
Yeah, I agree with you. Well, that's a good point you made about, for many years we were sort of told not to use hormone replacement therapy.
Yes.
And more recently that's been fortunately reevaluated, and now it's back on our treatment armamentarium.
Yes. But it's not a panacea, though, when it comes to cognition. Right. And I hope that that's one thing that we will be able to make clear in this podcast discussion, that, estradiol is not the treatment for everybody or everything. And that we need to be discerning still about what is in our pharmacologic armamentarium to help women who might be having executive functioning difficulties as they go through midlife.
Yeah, absolutely. And of course, we're focusing on ADHD, but as we know, there are many other conditions that can be associated with this and can get worse at menopause: depression, anxiety, and so on. And then there's the normal aging and the fact that some people do develop dementias, unfortunately.
Yes. And it's twice as common in females, some types of dementia, so like Alzheimer's disease. And so it is understandable why women are asking more questions of their doctors. Do I need to be worried about these changes that I have experienced in my cognition? And how do I know if I should be getting neuropsychological testing or brain imaging and all of these very expensive evaluations? Or do I need to try, mindfulness and be less stressed and get a better night's sleep? Those are all very valid questions.
They certainly are. Well, how do we sort out, when a woman presents with these complaints, how do we sort out what is going on here?
Yes. Well, there's a couple of things. One, I do try to determine with every woman who comes to me, no matter what age, but I particularly see midlife women. I do try to determine, did they have a lack of diagnosis of ADHD. Because we do know that females do develop ADHD. They have it during childhood, but they're less likely to be diagnosed. And symptoms of ADHD in women may look different. I mean, for example, women may be more chatty and talk more, be more impulsive in maybe not substance use, but more impulsive in decision making and things like that related to interpersonal relationships. So there's a lot of ways that you can start to talk to people and ask about symptoms in childhood. Did they find that they were, daydreaming a lot? Yeah, I daydreamed a lot, but I made straight A's. Again, intelligence and being smart and being able to know what's socially appropriate in a school setting can also hide the fact that you do have some executive functioning problems. It may be in working memory. It may be in processing speed. And it may be that it's different types of processing speed for different types of information. So I try to clarify, did they have ADHD that just was not diagnosed? Then what I try to do, and I have this little game that I play when I give presentations. So I'm going to ask our listeners to use their mind's eye to try and imagine what I'm talking about. So what's the difference between menopause and just normal aging and concern about dementia? And so I will ask our listeners right now, we're going to close our eyes and we're going to think about a big plate of the fluffiest buttermilk biscuits you can ever imagine. Okay, so you got this big plate of buttermilk biscuits. And then I want you to imagine that you're about to leave the house, you're rushing out at 8 o'clock or 7:30, whatever your time is. And you go, oh my God, I get to the car and I know I've got to go back in the house and get something. You rush back into the house and all of a sudden you're going, what did I come in here for? I mean, come on, Andy, you've done that. Yes, it does happen. It does happen. So what has this got to do with cognition? Well, basically the pathophysiology of a dementing process like Alzheimer's disease, it typically starts in a part of the brain that we refer to as the hippocampus. Now, the hippocampus is related to the buttermilk biscuits. How is the hippocampus related to buttermilk biscuits, you might ask yourself? Well, I basically say, look, I grew up in a small town in North Carolina, and I learned how to make buttermilk biscuits when I was very young. And I have made biscuits my whole life. If I get up one Saturday or Sunday morning and I'm going to make biscuits, and I forget the ingredients or I forget the steps and I find myself very confused, I would be concerned about that because that is something that is in my long-term memory. It's a rote procedural memory. Okay. Now let's take the example of going into, outside and then coming back in, or going into a room and not remembering why. That is much more reliant on something we call the prefrontal cortex. And maybe your listeners know exactly what I'm talking about, but it is the part of the brain that is often taxed by lack of sleep, being stressed, having a high cognitive load, and being, worried about things. And you have to understand, you took yourself out of one situation and came into an environment that, even though it's familiar to you, it's like the mice when you have a mice going into the novel area and the not novel area, and you're looking at their working memory. That's more of a working memory kind of task. You're trying to hold information in your mind. What did I at the car, I need to go get my lunch. I forgot my lunch. I come back in and I'm in the mudroom and I'm going, but what did I come in here for? Is it my jacket? Because you're now in a new situation. You're in a new room and you have changed things up. So novelty, having lots of balls that you have to keep in the air is more reliant on the prefrontal cortex. That's more a part of normal aging. Now, I would say it can be different at menopause because both the hippocampus and the prefrontal cortex are affected by estrogens, but particularly estradiol. But it seems to show up more in our executive functioning. that some women, because of loss of estradiol, are going to have more of these sort of executive functioning kinds of problems, less so the kind of procedural memory problems. That's how I tell people to think about it differently. If you can't remember how to make buttermilk biscuits, it may be for you your mother's lasagna. I don't know. But if you can't remember that and you're forgetting steps, like forgetting steps to your doctor's office that you've gone to for 10 years, those are things that you do start to say, maybe I need to see my doctor and talk about a neurological workup. But the walking into a room or forgetting or leaving my keys and all of those kinds of things are more executive functioning oriented.
Got it. And of course, the prefrontal cortex, we think, is largely affected by ADHD.
Absolutely.
So
Absolutely.
It all fits together.
Right, it does. And for some women, based upon their genetics, they metabolize dopamine differently and at different rates because of when dopamine is released based upon their genetic profile, they might be a fast metabolizer or a slow metabolizer. Well, estrogen actually affects that process. And it impacts. And so you might be at the sweet spot with respect to the amount of dopamine you have in the prefrontal cortex when you're at high estrogen levels. But for another person, that might be too much for them. And it puts them on that end of having a little more dopamine than is best. Maybe they get, instead of having cognitive flexibility, they might get stuck. Whereas somebody who's low on dopamine might need that estrogen. And again, part of that has to do not only with receptors and how sensitive they are, how much dopamine you produce, for example, as well, but how you catabolize it and your genetic profile that impacts that catabolic process.
That's interesting. Just this morning, I was reading about genetics and ADHD, and of course, there's been a number of GWASs and other articles published in the past few years about this, and a lot of them do center around genes that have to do with dopamine processing and synthesis release receptors, as you said. So
Yes.
that certainly makes sense.
And then you add the hormonal change on top of that. So that's why it's not all about estradiol, whether you have high levels or low levels. It's like it's your substrate and your genetics. And so that makes a really big difference. And that's one of the reasons why I can't tell people, oh, yes, estradiol is going to solve this problem for you. And one of the reasons that we did studies using the psychostimulant lisdexamfetamine is because I was getting referred a lot of women who were complaining of cognitive difficulties. And it was back in the early 2000s. And I felt like, God, this sounds like ADHD. So I was at Yale at the time. I had Tom Brown as a faculty member there, and I reached out to him. I said, Tom, in your practice, are you seeing these middle-aged women? And he goes, absolutely, we should study this. And so when you see women who can't take hormone therapy, and they've been suffering for years with these executive dysfunction issues, then you want to figure out how to help them. And I'm like, okay, if the phenotype looks like new onset ADHD, can we extrapolate using the medications that are FDA approved for ADHD? Can we use it with some effectiveness in this population? And we've produced multiple papers now, both in people who've undergone natural menopause and those that have undergone a surgical menopause, and been able to show that, yes, it is better than placebo. And everybody served as their own control. And I can tell you that some of these ladies did not know when they were on the stimulant.
Really?
I mean, everybody,
Yeah.
oh, no, I'm not kidding you. They don't have, I mean, it's not like they grew up with ADHD, because to get in my studies, you couldn't have had ADHD.
Oh, I see. Okay.
Because I was really looking at new onset. And they didn't really know what to expect. And it was very safe and well tolerated. And ultimately, I think it should be considered as an option for people that have these new onset executive functioning problems when they go through these hormonal shifts.
Well, this might be a revelation to our audience because, stimulants, of course, have all the baggage and all of that. I've done many stimulant studies for ADHD. That's been one of the things I've done a lot. And one of the criticisms is that stimulants unblind themselves, that people kind of know they're getting them. But that is not always the case, especially with an extended release, maybe smoother acting stimulant. So that's interesting.
No, and we did ask women whether they got the active or placebo. And because women could compare how they were on one versus the other. I mean, I actually had one patient who felt like she must be on the active drug because she was winding up having some behavioral side effects. And we basically decided to take her out of the study. And when we unblinded, she had been on placebo.
Oh, yeah. That's amazing.
I'm telling you, and I had so few women need to stop the study. But we did a gradual dosing. We started, and we didn't make people, it was based upon the level of tolerance because, again, I wasn't treating people with a diagnosis of ADHD because they couldn't have that diagnosis. But their scores on the Brown, Tom Brown scale for ADHD, I mean, they were in like adult ADHD ranges, many of them. And so it's not like these people were not affected. And again, as I can say, that a lot of them did not know when they were on the placebo versus the active. And I thought that showed that the blinding was actually pretty good.
Exactly. Yeah. No, it's fascinating, this concept of the cognitive impairment of menopause being similar to that of ADHD. That is kind of a newer concept, and that is fascinating, and it makes sense neurobiologically from what you're saying. But I am also struck by how often, as you've said, women are missed with ADHD, and they can compensate. And I had a professor once, you talked about someone who's smart. I had a professor who used to say, IQ points can compensate for a lot.
Yes.
That's one reason it gets missed. Or,
yes.
Obviously, if you have a mother or family, that helps you compensate and organize and this kind of thing. Of course, we know that the fastest growing group of people being diagnosed with ADHD is adult women. The fastest group of people getting on medications is adult women. So that's certainly interesting. One of the things that one of your talks that really got me thinking is a woman who's had ADHD and let's say is being treated, then gets to menopause, and now the dose of the medicine or the medicine itself is not adequate. And it got me thinking we shouldn't be setting it and forgetting it. We should be thinking about being more dynamic, maybe increasing the dose, maybe augmenting, maybe switching, something like that. What do you think about that?
No, I think that when it comes to, we say women's mental health, but I'm a reproductive psychiatrist, meaning I really study how and think about how hormones affect the female brain all across the lifespan. I even look at sex differences, for example, in preconception, and how maternal early life stress impacts the offspring based upon the offspring sex. And so there's a lot of ways in which, we really think, I started out my career in perinatal and realized very clearly that, the perinatal period is like a mini menopause, so.
It's true. It's funny you say that. When my wife was pregnant, she said she had pregnancy brain. And then when she hit menopause, she had menopause brain. So I know exactly what you mean. My
brain did well during pregnancy. It was postpartum. Then I had postpartum brain.
Of course.
So what is very similar between a postpartum woman and a menopausal woman? Lack of sleep, new stressors. So like you said, middle-aged or, adult women are like the fastest growing group of women that are a group of people that are seeking treatment for ADHD or newly diagnosed ADHD. Well, if you think about it, the population of people that are about 45 to 55, that is the fastest growing population in the workforce. Yes. Yeah. But then it drops off. So like 75% of women in that age group of like 45 to 55 it's about 75% are in the workforce. They're busy working. And then it drops off around the age of 55 and it goes down to in the 40s. And so basically it is estimated that 10 to 20% of women that leave the workforce at that window of post-55 are doing so because of menopausal symptoms.
Really? That's incredible.
Yes. And menopausal symptoms, including these cognitive concerns, are costing the U.S. economy about $8 billion a year in lost workdays and leaving the workforce. So we're losing about $8 billion in our economy. And menopause is a range of symptoms. It's not just the cognitive. So I do want to say something about the fact that, why do you think that this might be happening? Well, I got promoted to being a chair of a department when I was in my mid-50s. My cognitive load and the number of things that I was asking my prefrontal cortex to do increased exponentially. Then I moved my elderly parents to Denver so that I could keep a better eye on them. And my mother got sick right away. And so now I was dealing with a relatively new job, a sick elderly mother, and their transition. So my prefrontal cortex was stressed beyond max. Yes. Okay. So of course I'm going to forget things. Of course I'm going to drop balls. And I know enough about what's going on that I didn't go all of a sudden, oh, maybe I've had ADHD my whole life. No, I have a lot going on right now. And now let's take a woman who is having either a worsening of her ADHD symptoms, or let's say she went through a surgical menopause. And we really should separate natural menopause from surgical menopause. And I would say that if you're treating women with ADHD that are undergoing a surgical menopause, then you really do have to think about how this is going to affect their prefrontal cortex. And yes, you probably are going to have to adjust their medication, because a lot of women are undergoing surgical menopause, about 250,000 women in the US every year. And often they are told to do this because they're at genetic risk for cancer. And the oncologist will tell a woman who's BRCA1 or BRCA2 positive that they should have their ovaries removed and possibly their breasts removed before the age of like 38.
Wow. Yeah.
That's really young.
It is. Yes.
And you go from a normally menstruating woman, maybe one that's even taking hormonal contraception, whatever it is, you've got estrogen on board. Now you're within a day, you're postmenopausal.
Wow.
And the kinds of problems like vasomotor symptoms, sleep difficulties, cardiovascular issues, osteoporosis, weight gain, all of those things are accentuated for that woman who has undergone an early surgical menopause. And so I would say everybody has to really think about that population as being quite at risk, because we all know, let's say you have a diagnosis of ADHD. If you're staying up all night and not sleeping well, you're not taking care of yourself in other ways, then your cognition is going to stink.
Of course.
Because that's true for everybody. But if it's like if your prefrontal cortex is hanging on, it's really hanging on by a thread. And you add sleep deprivation, and you add loss of estrogen.
Yes.
I mean, yes, it's multiple hits. That poor prefrontal cortex is going, help me.
Yes. Well, I have an interesting story about that. I was recruiting for an adult ADHD study one time, and a woman came into the study, and she had ADHD, but when the wheels fell off for her, when she really needed to get help, was after her fifth child, Neill. I was like, wait, 4 kids were okay? Well, she had her mom helping her. But the fifth one is when the demands of the load finally got to be too much. And
exactly.
So everybody has a different tolerance for stress, and everybody has different compensation mechanisms and help and all of that. Mm-hmm. But you're right. It makes perfect sense that we have to think about these transitions. And we have to think about all the different things. I mean, I'm also resonating with your story about your parents. My wife, our boys are finally in college, and we thought, great, she can travel with me now. And then her mother developed Alzheimer's, and she's the primary caretaker. So now all of a sudden she's thrown back into that role.
Yes.
It's very stressful.
It is very stressful. And mid-aged women are dealing with that, and because often, when we're finally getting our kids off to college, our parents are aging into these experiences, whether it's cardiovascular disease or dementia or something else. And as a physician, and the only physician in the family, there's a sense of responsibility too. Okay, well, I'm supposed to keep an eye, and I'm supposed to be more educated about what they need. And And frankly, it's incredibly emotionally stressful as well.
Yes, I can imagine. Well, and of course, women are primary caretakers typically in the family, so that makes sense.
Yes, it does. It does.
Now, of course, we know that two of the most common comorbidities with ADHD are depression and anxiety. So if you throw that into the mix, boy, it really gets complicated.
Well, I think also that is absolutely true. But I also think that when you are looking at the perimenopausal woman and then the woman who's undergone a natural postmenopause. So again, just to be clear, postmenopause, you become, quote unquote, the day that you're 12 months since your last menstrual period.
Exactly. Yeah.
Woohoo! This is the day I'm postmenopause.
It's such an artificial distinction. Yeah.
And then everything up in it. And again, the average menopause, perimenopause to postmenopause is about 4 years. But there are a lot of women that go on and have symptoms for 6, 8, 10 years. And so it's a highly variable length that you're in the perimenopause. And for some people becoming postmenopause, they really feel like their symptoms are much, much better. But I want to get back to this idea of sleep and anxiety and depression, because we did a study, again, during the pandemic. You make lemonade out of lemons, and we couldn't bring women in for our menopause study. And I had always wondered, what's really the sort of self-report of executive dysfunction among individuals out in the community that are not going to be seeking to be in a study or what have you. I mean, so we basically went through a couple of organizations, different clinics that have a lot of postmenopausal women, we did use research match as well, which we know is a skewed sample. But we looked at about 1,800 premenopausal women, perimenopausal women. And then we took the postmenopausal women, and there was the natural menopause and those that underwent a surgical menopause. And I can tell you the if you use, let's say premenopause, we used it as the sort of the baseline. Perimenopausal women, great increase in their executive functioning complaints. Scores on the Brown Attention Deficit Disorder Scale skyrocketed. A slight attenuation in the group that was in the natural postmenopause, but still quite a bit higher than, and then in the post-surgical, they were the highest level, highest scores. Again, high scores on the bads is bad. So, you could say, well, we controlled for ADHD, self-reported ADHD, attention deficit diagnosis. Yes, exactly. We control for them. Age and education saw these big gaps. We started to control for insomnia, and we used a self-report insomnia scale that's very much used in the research. We used clinically meaningful depression levels using standard questionnaires, and the same thing for anxiety. When you controlled for insomnia, depression, and anxiety, you saw the same pattern. It was just diminished. The differences were less. And what this says to me, that some of these spikes that we see in perimenopause, and particularly with our surgical postmenopausal women, may be because we're ignoring some of these other symptoms like depression, anxiety. And again, these were not people with diagnosis. This was people who were doing standard instruments. If I said them, everybody would probably know what they are. And basically said, okay, if you meet this criteria, kind of score of 16 or above on the CESD, or, I forget what the one on the GAD-7 was. But again, these are accepted cutoffs. You saw that it really did play a role in people's executive functioning. Even in these perimenopause and postmenopause populations. So when I give talks to primary care providers, whether they're family medicine, internist, OBGYNs, I ask them to really dig deeper if their patient is talking about cognitive issues, because, even mild insomnia, mild depression, even mild anxiety, these combinations, which are very common in menopausal women. I mean, we know that there's an increased risk for depression and anxiety in the perimenopause. So you need to look for those and also attack those in a way that could be helpful. This is where estradiol can be often very helpful, especially if there's no contraindication. See what estradiol will do. How much cognitive benefit can you get if they start sleeping better? They don't have hot flashes at night waking them up. They're maybe a little less depressed and again, a lot of menopausal depression, people will almost describe it as ennui. Like they just don't feel the same joy in life, which I always think, that sounds dopaminergic to me.
That does. Sounds like anhedonia. Yeah.
Exactly.
Yeah.
But otherwise, they would say my life is good. It's stressful. So I think if you can tackle those things and then see how much benefit you get for these executive functioning complaints, but if you don't get people to a place where they feel like, yes, my executive functioning is better, I can pay attention, I can do the things that I'm less motivated to do. I remember complex, decision making and all of these things. Don't not use a stimulant just because because again, this is a person who may just need a little bit of a stimulant. We basically saw in our study that there was really no added benefit above 40 milligrams with a lisdexamfetamine. And that, they kind of plateaued at that point. But we titrated people from 20 to 40 to 60 if they tolerated it. And most people did get to 60, but I would say that I didn't really see much of a benefit above the 40. So again, 20, sometimes I start people with 10 clinically just to kind of see but again, I do that if I can get them sleeping, if I've managed their depression and I've managed their anxiety.
Yeah. Well, of course, you alluded to this earlier. There is the inverted U-shaped curve.
Yes.
In the prefrontal cortex, but also with dopamine. And if you drive stimulant dose too high, you can fall off the curve. So
exactly,
that's really interesting to think more in the moderate range of dosing here.
Exactly.
Because you're not really treating ADHD per se, where I would probably push a little higher. I do have a question, though. You made me think of something. Can estradiol, independent of the benefits you mentioned for cognition, can estradiol itself treat depression or anxiety or help those?
There are a few randomized clinical trials of estradiol at relatively normal. They may be a little high. They were like 100 micrograms per day, and they were patch studies. I think most people will start women off in the menopause transition around 50. But it used to be that it was standard to kind of start with either the oral equivalent to 100 micrograms per day or a patch. Now people are like, people's symptoms do seem to improve even at lower doses. But these studies did use that higher dose of estradiol. And they did show that in women particularly who had perimenopause onset, so their depression seemed to be more hormonally triggered, that estradiol was significantly better than placebo. And relatively small samples, but definitely an effect there. And so I can say clinically that if I see a woman that has, a constellation of symptoms, if there's no reason that she can't take estradiol, and she's interested and open to hormone therapy, let's say she has some hot flashes, sleep difficulties, maybe some night sweats, that are bothering her. And she's complaining of low mood. And even if she doesn't meet criteria for major depressive illness. Now, if this is her very first episode and she does meet criteria for major depressive illness and there's not suicidality as an issue there, I will probably start that woman on estradiol before I would even reach for an antidepressant. Because I think that the estradiol is going to help all these other menopausal symptoms that could be contributing to her really not feeling well. And so in any case, I obviously keep a close eye because I want to make sure that I'm getting the kind of symptom response that I'm hoping for.
Well, that's kind of what I was getting at. I mean, rather than just rushing to start the estradiol and the antidepressant, you might be able to so-called kill more than one bird with one stone there. So maybe start with that first, see what's left, and see what you got.
Mm-hmm. And I would say, again, to do that before I would start a stimulant.
That's my next question. Yes.
Unless the person clearly had an ADHD diagnosis that was just missed. But even then, I'm going to want to look at all of these other things that estradiol could potentially be beneficial for. Now, we do also know that SSRIs, for example, several have been studied in the treatment of vasomotor symptoms because serotonin and norepinephrine are involved in hot flashes. And so now we have non-hormonal treatments for hot flashes as well. So as we go on, there's more and more coming out that says, okay, why would I choose this versus this versus this? And I just really try to look at the individual when it comes to sort of the executive functioning issues. Do they have a misdiagnosis? And now we're seeing it because maybe there's more stress. Maybe there's more cognitive load. Maybe they're perimenopausal. All of those things. And I would probably, especially if there were a lot of typical perimenopausal symptoms, I do tend to start with the estradiol first.
Yeah, that certainly makes sense.
Yeah.
My understanding is SNRIs are better, even better than SSRIs. There were studies of desvenlafaxine that were very positive. And I actually did a study, Neill, you'll love this, women with depression and vasomotor symptoms of menopause with desvenlafaxine, and it was incredibly effective for both. I had husbands, boyfriend, partners coming in to thank me, essentially. I know, I don't mean to sound sexist here, but it can obviously affect relationships tremendously.
Yes.
Now, let me ask you this. If a woman who clearly has pre-existing ADHD, whether treated before or not, and many of them have not been treated before, would you consider starting both at the same time, the estradiol and the ADHD, because you clearly have an indication for a stimulant, maybe?
Yes. I'd have to be really convinced that it was a misdiagnosis and not new onset ADHD symptoms. And so I have a tendency to call what I see in the menopause executive functioning complaints, because obviously diagnostically they cannot have onset, after a surgical menopause. It doesn't fit the DSM. So I try to refer to that. But if I'm really convinced that this is a person that just had missed ADHD diagnosis, and if it was that it was really concerned about, and that was my primary issue, yes, I'd probably start the stimulant first. But if I really thought that it was also perimenopause playing a role, not everybody can come back for appointments. But the thing is that, like we're all taught in training, if you start two things at the same time, you don't know what works.
Exactly. Right. I think wise pharmacology is always one thing at a time. But I was just wondering, some might be a situation.
Well, not all psychiatrists are willing to start hormone therapy. And so if you're in a situation where you're like, I'm not starting hormone therapy, I don't know nothing about hormones, then, and I'm going to have to get this woman to be seen by her OBGYN, I can start the stimulant because she's here in my room, in my office. Yes, of course, you're going to do that, because I can tell you there are places in the country where trying to even get a gynecology appointment is unbelievable.
But I guess what I'm taking from what you're saying is maybe take your time. Start with a lower dose of the stimulant, titrate gradually until maybe you can see what the estradiol does. And with estradiol, maybe you don't need as high a dose of a stimulant, for instance.
That is quite possible. That study has not been done that I know of. But it does.
Well, there you go. There's an idea for a new study.
Oh, I've got so many.
I'm sure. It really is an exciting and important field clinically. I get asked about it all the time. And at NEI, it's one of our biggest, we do needs assessment surveys of our audiences and our members. And boy, it comes back very commonly. ADHD,
really?
Women's mental health, ADHD, and women with ADHD. All three of those buckets are really, really common. Yeah.
Well, I often will do national studies. My last psychostimulant study, I recruited people all across the country. And basically they all said to me, my doctor, I've been like this for 5, 10, 15 years, and my doctor has had no idea what to do to help me. And it's a shame. And I have to say, it's one of the reasons I agreed to do podcasts and other kinds of media is that, how do you get the information out there to the lay person so that they at least go and have the conversation with their provider. Of course, I'd like all providers to understand that these are issues. Do not poo-poo cognitive changes. Do not do that. But, sometimes it's really up to the patient to advocate for themselves.
Yeah, that's a very good point. There's another area in the differential, let's say, or in the assessment we haven't talked about, and that's the effects of medication. Substances. I mean, marijuana is so common now. You're in Colorado, my gosh. It's so easy to get there.
And older people are using cannabis at a greater rate. They're the fastest growing population.
I know. I definitely know what you mean. But the effects of prescription medicines, too. People may be on anticholinergic medications, for instance, or sleep medicine, sedatives, whatever. I think we have to look at that, too. We've got to look at the whole bucket, because very often, as a psychiatrist or mental health provider, you may not be focusing on all the other meds.
Yes.
And so I have something, Neill, tell me what you think of this. I call it the shopping bag trick. I have a woman fill up a shopping bag of every bottle in her house, over-the-counter, prescription, whatever, and I'm always amazed what I see.
Oh, wow.
Yes. Yeah, you'd be quite surprised.
Well, they also don't make it easy to get rid of old medication.
It's really true.
The pharmacies take them. I'm like, oh my gosh. And then I get to that pharmacy and I see the basket and I'm like, I'm taking that.
Well, you'll see things like medicines prescribed by another provider you didn't know they were taking. Or
sure.
Neill, I had this. You won't believe this, but I really had this. A woman was taking a bottle labeled lorazepam. Another bottle was labeled Ativan, and she was taking them both because she didn't realize they were the same thing.
Oh, wow.
Yes, I know. What? These kinds of things. So it's something simple to do, but sometimes just cleaning up the medicine could be helpful.
No, I think that's really smart. I think every single provider that listens to this podcast should do the Andy method.
Yeah.
The shopping bag.
The Andy Cutler shopping bag trip. Yeah.
Yes.
Yeah, that's right.
Yes.
So, it sounds like that you have to do a careful assessment of all these different factors. There's also one other intervention, I'll say not treatment, I want to ask your opinion of, and that's exercise.
Oh, yeah.
We know exercise is good for the brain. There's actually studies of exercise helping with ADHD, for instance. What about exercise in a woman going through these transitions?
Oh, sure. There's a number of investigators that do study exercise in midlife individuals, and some have focused on midlife women, for example. And there's very interesting data regarding the type of exercise. So, for example, this woman who's a Canadian researcher, I think she's in British Columbia, and Ambrose Louis, I think is her last name. But in any case, there's also some consensus statements, too, about not only the type of exercise, but how much of that type of exercise that people can search online. And I would arguably say that different kinds of exercise based upon this individual and others' research has more of a positive effect on prefrontal cortex functioning. And they do assess this by how do you perform on tasks that are really, that prefrontal cortex driven versus, for example, hippocampal, because we're going to get back to that hippocampus and think about the fact that, yes, estrogen has a lot of effects on the hippocampus as well. And so, we really have to be thinking about that particular brain structure and how to keep it healthy as well, how to make sure that there's neuroplasticity. So I think exercise is really it's promoting neuroplasticity, and the research has shown this. And so what I try to help people in lay audiences understand is, even though Plato basically said, the lack of activity, ruins the good condition of every human being, while methodical and physical exercise saves and preserves it. So
really, I didn't realize.
Oh no, that was Plato. That was Plato.
Oh my
goodness. Wow. So maybe not the exact words, but that's the point. So I try to tell people, I'm not, don't roll your eyes when people tell you that exercise is good for you. This is, we've known this. We've known this. We just have scientific tools now we have cognitive assessments, we have neuroimaging, we have the ability to measure BDNF and see what effect that has in the hippocampus or the prefrontal cortex when the individual exercises. Obviously, the more mechanistic work is done in mice and preclinically and other animals, but in humans, you can at least do imaging. You can measure mood. You can measure, like does exercise, for example, exercise decreases the risk of recurrence of breast cancer too. So
Wow.
there's a lot of reasons why people should be exercising.
Exercise is not only induces neuroplasticity, it's neuroprotective, but also it's anti-inflammatory throughout the body.
Yes,
which of course is good for the body and the brain.
Yes, it is.
What's interesting about what you said, the type of exercise, there actually is literature in the depression field that boils down to FIT, F-I-T. It's the frequency, intensity, and time that you exercise. Mm-hmm. And it turns out it should be aerobic exercise. The frequency only needs to be about 3 times a week. The intensity is to the point where you're just getting a little bit short of breath. You don't have to be fully out of breath. Mm-hmm. And the time, they say, is 20 to 30 minutes.
Yeah.
So I think that's something many people can work into their routine.
Yes.
Well,
yes, many people can.
Well, yeah, it's not for everybody.
Well, the thing that worries me about sort of like this whole push right now at the national level that we're all supposed to exercise and eat well, and and we all know it, but there are disparities, and I'm going to say that word, between who can actually eat healthy and who doesn't have access to these healthy foods, who has a safe neighborhood to go and do this aerobic exercise, and who doesn't have a safe neighborhood. So these are things that I always feel a little bougie touting exercise and healthy diet when we have to really think about how do we help all of us have access to the capacity for exercise and diet. And I would say that even if you live in a very safe neighborhood and you have access to even really great food, if you're, basically rushing around working and, using your prefrontal cortex to its max, and you don't get home to 7 o'clock at night, and you got to stop by and see your elderly father at the skilled nursing facility, which is what I'm doing right now. And I do have a husband who's willing to cook, but not everybody does. There's nights I come home and go, oh, God, let's just have a bowl of cereal.
100%. Or you stop at a fast food restaurant on the way home, of course.
Yes.
Yeah,
and so,
of course.
The thing is that when you have lived experience, knowing that even if you are in a situation of privilege, because I love my job, I don't hate my job, I love my job, but my job is very taxing on the prefrontal cortex. So I don't always want to come home and make a nice meal. I sort of refer to the prefrontal cortex as, like your bicep, So like if you were to go to the gym, let's just, again, fantasize that we're all in a gym and we have a barbell, even a 5-pound barbell, and we lift it all day long. We maybe stop to go to the bathroom, but we come back and we lift that barbell all day long. Our bicep would be screaming at us. I mean,
I know.
We'd be screaming.
I'm tired just listening to you describe that.
But, we slog our prefrontal cortex.
That's right, yes.
Like somehow it's supposed to be able to do Olympic gymnastics.
Well, I would say, Neill, especially women, I think we have to acknowledge that women tend to be, as I said, primary caretakers. They may work, they may have childcare, older adult care, they're managing the household. Not everybody has an enlightened husband like yours, maybe, who can help out with those things. So I think the cognitive load can sometimes be especially high on women, even higher in some ways.
Well, I do think that, again, it's one of the reasons that there's a drop-off in the percentage of women 55 and older that are still in the workforce. And so we are losing a large percentage of people due to midlife changes. And they're probably not all biological. They're certainly not all hormonal. But it is remarkable, the estimate on the number of days missed of work because women are taking care of menopausal symptoms.
Wow.
I mean, again, it's
another shocker.
It is. It is. I mean, if, give me a second. 4.9 million lost days of work attributed to menopause symptom management. And that is from the U.S. Bureau of Labor Statistics. And yeah.
Well, Neill,
Yes.
Neill, I can't believe how fast this time has gone, but we are actually approaching our time here. And we've got to do another one because you've given me some ideas for other podcasts.
Oh, that's
here.
great.
I really enjoy speaking with you.
Well, it's been a pleasure. It really is.
But
Thank you.
Before we end, I do want to kind of wrap up and maybe leave our audience with some takeaways. So we've talked about the assessment of cognitive complaints in women across the lifespan. We've talked about management a little bit, including both pharmacologic and lifestyle and others. What would be your key takeaways? What are some of the things you're seeing or that you think if we could just get this message across, this would help?
Yeah. I think women shouldn't suffer in silence. And I think that women are known to often not want to bother their health provider. So they go for their well checks and what have you. And if your patient tells you that they're having symptoms, do not ask them, are they bothering you? Because the fact that she brought it up, it is bothering her. Because as soon as you say, is it bothering you? The woman is likely to say, oh, no, I can't manage, So please, as a provider, ask for more details and assume that it's bothering her because she brought it up. And women also have to educate themselves to go to their providers and say, I would like to talk about this. And if I have to come back to get an answer, I will do that.
Well, it sounds like it needs to be part of the routine screening and assessment of any woman as they're approaching middle age.
Yes. And I think the psychiatrists and psychologists and APPs and others in the mental health continuum really also need, even if you've known this person for 10 years, don't make assumptions because their body is going through changes and these biological changes can have a dramatic impact on even what might have been a stable illness. But another episode of depression, you should, especially in somebody who's 46, they've been stable, you're going to ask them, hey, what are your periods like? So I guess I would say that the bottom line is be curious. And
I like that. Love that. I've always said to be a good clinician is to be curious.
Yes.
It's one of my Cutlerisms, if you will. I have a number of those.
Oh,
I suppose
great.
You have Eppersonisms too, I can tell.
We call them neologisms because I make up words.
Like neologisms.
They just sound right.
Yes, I love it. That's fantastic. Well, and the other thing I want to mention, of course, as you said, a patient you've known all these years, let's not forget, as we've talked about, there are environmental changes that happen and psychological changes that we've talked about in the career and in your family and so on. So, wow, this has been tremendously enlightening, I think extremely helpful and relevant clinically. I love the idea of getting people to advocate for themselves, but also getting healthcare providers to just be a little more open-minded, a little more enlightened about this. And some of the practical tips, I think, about management when we talked about the estradiol, an antidepressant, a stimulant, sleep management, my goodness, I don't think we talk enough about that.
No.
These are all extremely helpful things.
Yes, and a lot of people use alcohol or cannabis to help them sleep.
That's so
and
true.
And I'm telling you, if you have a bad case of insomnia and cannabis works for you, good luck getting that person to stop. And so part of it is that you need to understand what role these substances are playing in people's lives. And then just, try to understand that. Again, be curious because coming across as judgmental in any kind of doctor-patient relationship is it's a killer to the relationship.
Yeah. Well, I've sort of learned the hard way. When I was earlier in my career, abstinence I thought was the goal. I'm now at the point, abstinence short-term is not a reasonable goal. Harm reduction is my goal. If I can just get you to use less or maybe...
Exactly. And the data is showing very clearly, particularly when it comes to alcohol, that if you reduce from like 6 drinks a day to 3 drinks a day, that doesn't matter when you do that, there are health benefits. And so even the FDA is starting to soften up on clinical trials related to treatments for substance use disorders.
No, they have, because I did some of those early in my career, and total abstinence was the goal.
Was the only
thing. It was the primary outcome, right? Now it's not. There's things like problem drinking, binge drinking, days drinking, and so on.
Exactly.
Much better.
So I do think it sets up the doctor-patient relationship or the therapist-patient relationship to be less adversarial. If you start talking about truly, what do you think you can do? And any amount that you can reduce is actually going to be helpful and have health benefits. So in any case, we could talk about sex differences in substance use if you want to do that in the future.
I certainly do. I found this incredibly enlightening, and I want to thank you so much for your time. And I want to thank you, the audience, for listening to this. And for more information about NEI and our educational offerings, please go to our website, neiglobal.com. And these podcasts, the NEI podcast, you can find them anywhere you get podcasts. So, Neill, thanks so much for your time.
Oh, well, it's been my pleasure, Andy. Thank you so much.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.